we're going to go ahead and get started tonight. Thank you to everyone who is here for our Zoom chat about breast implants and breast implant illness. We really appreciate you being here to learn more about the signs and symptoms of a breast implant illness, which we'll call BII throughout the night. We want you to know more about what your options are if you think you may have BII, and we'll also open up the mics. So get your questions ready and you can ask questions. Before I get started, I do have a couple housekeeping reminders. So first, this event is being recorded. The video of this program will be published to the Executive Plastic Surgery website and social media channels. There's always a possibility that it may also be shared on media platforms that are outside of the control of executive plastic surgery. So please keep that in mind if you're planning to share any personal information when you ask your question. Right now, everybody is muted. If you'd like to ask a question, please wait until we call on you to unmute yourself. If you repeatedly unmute yourself out of turn or otherwise cause a disruption, we do reserve the right to remove you from the room. Additionally, profanity and explicit language will not be tolerated, so if you use it, you will also be removed from the room. So there's two ways you can ask questions. If you'd like to verbally ask a question, you can select the raise your hand option. So depending on your Zoom setup, you might find that option under the participants tab, or you may find it under the reactions tab. We'll also call for verbal questions in the order that they are received. If you don't want to ask your question out loud, you can send it in written. Feel free to use the chat box and type your question there. Again, we'll do our best to answer those chat questions in the order that they're received. So without further ado, I'd like to introduce you to Dr. Shaher Khan. Dr. Khan is a double board certified surgeon. He's board certified by the American Board of Plastic Surgery and by the American College of Surgeons for General Surgery. So Dr. Khan also has his bachelor's in biochemistry and did a burn fellowship in burn and surgical critical care. Dr. Khan is an MD, and his practice is devoted exclusively to the three following procedures. So number one, breast implant removal, which is also known as explant, en-bloc, or total capsulectomy. Number two, the removal of residual capsules. And number three, the flat closure after removal. So let's get started. With Dr. Khan, if you would explain what BII or breast implant illness is and how you developed the Khan procedure.
Yes, hello, good evening, everyone. It's a pleasure to be here to discuss what is a very important, a very hot topic, and an illness, the breast implant illness, also known as BII, that seriously afflicts not only the patient, but also the family members, friends, and also certainly the entire life, if you will. So what is breast implant illness? Breast implant illness is a constellation of signs and symptoms that basically is a direct result of the silicone toxicity as a result of leaching, not only from saline implants, but also from silicone implants, and certainly from ruptured silicone implants and textured breast implants that causes the many constellation sign symptoms of what is silicone toxicity that touches almost every aspect of the human body, from the hair follicles being affected, where patients have basically the hair loss, to the vision problems, migraines, personality disturbances, for example, anxiety, depression, suicidal ideation, along with the neck and back pain. And again, going neck down, it affects the breathing status, it affects the shortness of breath, and also what they say, dyspnea on exertion. When someone exerts themselves, they have this exertional activity, irregular heartbeats, they have a digestive system that's affected negatively. The hallmark feature of breast implant illness are the rheumatological problems, the fibromyalgia type symptoms. The patients have problems with connective tissue disorders, for example. Autoimmune issues is another hallmark feature of what is breast implant illness, where the thyroid function, adrenal function, among the many other hormonal systems, including the reproductive system, is affected negatively. And then certainly you have the bone and joint pain, again, the many rheumatological problems that afflict the patients are, again, touching almost all organ systems of the body. And one way to gauge the severity of this is to basically do a questionnaire checklist, if you will, of the many symptoms that are affected. And as you can see, look at the many different organ systems that are negatively affected, some more, some less. some periodically that come and go, like ringing in the ears, for example, or sign symptoms suggestive of what is Lyme disease. So it's a very broad spectrum of constellation sign symptoms of what is direct silicon toxicity.
I can see that there's a lot of symptoms here on the screen. Are there any symptoms that are more prevalent than others that you've seen in your patients, Dr. Khan?
So the most common symptom is fatigue. This is where a patient will sleep 8-10 hours, and despite a night rest, she will still feel very tired and lethargic. The joint rheumatological problems are also a very common feature of what is breast implant illness. And again, the many psychological factors such as anxiety, depression that also afflict, including the personality changes, suicidal ideations, like I mentioned earlier, that are the top three, I would say, major complaints that the patients present with.
Gosh, I keep looking at the screen and there's so many. Are there any that are more common that you've seen with your patients?
So the ones that I mentioned earlier are the ones, but again, as you will see, many patients, for example, will come in with basically chest pain, discomfort. That is a very common sign, difficulty breathing. As you can imagine, it's not only the mechanical pressure of the implant sitting on the chest, but also the inflammatory nature of the implant causing the chest pain and referred pain, sometimes to the shoulder or to the entire chest. The psychological factors, including the rheumatological factors, and along with the fatigue and brain fog being the most common of the top three, I would say, from the many patients that I've seen over the years that present with breast implant illness.
So with those symptoms, because some of them are are kind of overlap from other illnesses, we have a question in the chat here about what should I do if I suspect I'm being misdiagnosed? So
the first thing here is go to your primary care doctor and let him or her basically do a battery of tests. And again, there are not that many blood tests that need to be done. For example, checking the thyroid. You do not want to have a low thyroid level because that mimics what is breast implant illness. You want to make sure you don't have lupus, you don't have rheumatoid arthritis, Lyme disease, for example, low vitamin B12, amongst the many other factors. Sometimes patients have unknown diabetes, for example, advanced diabetes, and they were not aware. They may not have seen their doctor. So you want to rule out those organic causes. Now, this is the phenomenon of breast implant illness, a very classic picture. I've been to my doctor, I've been to my rheumatologist, I have the pins and needles, for example, the numbness tingling in my hands. My neurologist has ruled out any of those neurological problems. My endocrinologist has ruled out the thyroid, adrenal problems. Now, once these quote organic causes of illnesses that we know of as hypothyroidism or rheumatoid arthritis, lupus, Lyme disease have been ruled out, more and more fingers now point towards what is breast implant illness. Otherwise, what would be causing a young lady, be it in her 20s, 30s, 40s, even 60s? Last week, I took care of a patient, she's 72. She told me she does not feel like she is 72. She feels like she's in her 90s. Now, you would think that she is postmenopausal. She's 72. She is all the stresses of a 72-year-old, but she knew baseline deep down within her heart, this is not her. This is not her baseline, and her situation all of a sudden deteriorated. So she knew, because all those organic causes were ruled out. Now more and more fingers point towards breast implant illness. We know this, there are no lab tests and there are no imaging modalities, be it MRI or ultrasound or mammogram, that will diagnose breast implant illness. It is essentially a diagnosis of exclusion. And that questionnaire where the patients themselves fill out and highlight the symptoms that they are being affected by, that indicates to me and certainly to the patient that these are the many detrimental effects of silicon toxicity causing the breast implant illness.
I need to mind my mute button. Sorry about that. We do have another question for you, Dr. Khan. This is from Brittany. What if our labs are indicating Hashimoto's, and that's something that's new within this year? but have so many of the other symptoms. So she said her neurologist has ruled out most on his end, and she's soon to see an endocrinologist soon, but her thyroid ultrasound was normal. Would that be symptoms that you'd be looking at?
So if there are millions of people who have Hashimoto's, which is hypothyroidism, and they can certainly correct that with replacement of thyroid medication, be it levothyroxine or Synthroid or any other like T3 supplement, and you can quote normalize the thyroid values in that regard. Now, if someone, despite a normal TSH level, continues to hurt from the fatigue and the breast implant illness symptoms, we know that there is more to it than just the Hashimoto's, because that in itself has been corrected by replacement thyroid hormones. So now you will see that more and more of a indication that this is breast implant illness, still proven otherwise, because you have millions of patients who have Hashimoto's, who have no implants, and once they take the replacement thyroid, their thyroid function essentially normalizes, and then they go about to their normal state of health on a day-to-day basis. You would expect the same from a patient with implants, but if they don't recover despite normal thyroid levels, like a normal TSH, thyroid stimulating hormone, you will now indicate or be the suggestions clearly point towards other causes, and certainly breast implant illness is going to be one of the differential diagnoses, if you will.
So Brittany is saying that her TSH in T4 and T3 levels were normal. So it does sound like she should be having further conversations with her doctors.
Yes. Yeah. Now, this is very classically, you will see the patients now, the endocrinologist is going to say, well, there's nothing more that I can do. And now you have the fingers pointing towards breast implant illness. And we know from the past, from the many patients who have successfully explanted, that once the explant is done, where the entirety of the implant plus the capsule plus all inflamed tissue is removed, we see the patients bouncing back to a normal state of good health, and their brain fog and fatigue certainly normalizes and consistent with the normal TSH levels. But and another way to make the point, I would not operate on a patient who has high TSH, which means they have low thyroid, and because I want to make sure that they have normal thyroid function. Plus, I would not want to operate on a patient with low thyroid because they can get arrhythmias, other problems that are associated with hypothyroidism. So I want the patients to be, what I say is to have had a medical clearance, which means that the primary care doctor certifies, authenticates, and states that the labs are normal, EKG is normal, the rest of the body function is normal, and the patient now meets criteria for what is safe surgery, because everything else has been ruled out. And this is where I myself, having taken care of a lot of patients that come to me from out of state, I can easily, in my mind, I have that confidence that it is by default now the implants, and the primary care doctor has ruled out the problems.
That is very, that's part of your common procedure, I believe, to make sure that your patients are.
Yes. And the hardest part, if you ask me, there is before surgery, which is the pre-op workup, and you have the operating room itself, you know, what happens on the day of the surgery in the operating room, and then you have post-operative care. The most important aspect of breast implant illness is the pre-operative workup. They are extensive workup. For example, just today, I have had feedback from a patient who is 60. She has seen her cardiologist, she has seen her pulmonologist, she has seen her hematologist, and she has seen her primary care doctor. And I have two of those doctors who gave me the green light that she has been optimized. I myself sat down, and since last Wednesday, I have reviewed her chart literally on a daily basis, except for the weekend. And I have concluded she is not safe for me to proceed with surgery despite the clearances, because I don't want to be operating on her, and she has problems on the OR table and even afterwards. So for example, she had functional hypoxia, which basically means that when she would exert herself, she would get hypoxic. I want to make sure that she gets a stress echo She also gets a cardiac MRI because that was the plan, and she has been appropriately worked up before I proceed with surgery safely. I, as a plastic surgeon, as an MD, I have to make sure it's my responsibility that the patient meets criteria to proceed with surgery safely. If you ask me, surgery in itself is the easiest part of the whole process.
I believe it. I see that Stacy has a question. Her hand is raised. So Stacy, if you want to unmute yourself, you can ask your question.
Thank you. My eyesight's not the best, so I can't type on my little phone at the moment. So I'm sorry about that. Thank you. I appreciate you inviting me to the video. I had both ruptured implants and had them explanted 6 weeks ago now. Unfortunately, it didn't go the best, and apparently it burst on my surgeon and squirted everywhere. And it was more like a liquid, she said, than a gel, and it was unrecognisable that the implant had basically deteriorated so much. I was implanted in 2007. My question is, if that silicone, because it burst and therefore didn't come out all together, what should I keep an eye on, and what sort of things can I test for to see ongoing issues with that silicone in my body? Is there sort of things that I can toxicity tests or that sort of thing that I can possibly get done to see whether I've been, intoxicated all through my body? Does that make sense?
Yes. No, absolutely. Now, I will say this to you. It is heartbreaking to hear your story because you have what is frank spillage of the silicone into your chest. If you will see from my experience and expertise and as an explant specialist,
yes,
there are many patients that I've taken, and again, if I may use this as an example in my practice, there are many patients who present to me who have ruptured implants, silicone, especially the older ones, or even that are as old as 3 or 5 years, for example. If you look at the manufacturers themselves, this is a very heavy question, but I will go ahead and answer. The manufacturers themselves say that get an MRI at year 3, and then every 2 years they're onward to look for a silent rupture. So your surgeon should and must have thought that they should be ruptured till proven otherwise. The surgeon must always go into the surgery assuming they're ruptured, even if there is an MRI that shows they're not ruptured. Yeah, and the point is, yes, please.
Sorry. She knew they were both ruptured. They were under the muscle, and when she went in, apparently she couldn't find them, and they were so far up that she had to sort of cut my muscle to actually get into there. The implants have made no difference to my size because there was nothing of them. Basically, apparently the capsule was very thin, but pretty much no implant other than some. That she tested the capsule and everything, and it came back as no malignancy. But it
was
also,
the entire capsule removed?
Yes, both capsules were removed fully, but the silicone, it burst when she got in there, apparently.
Right. No, I will tell you, the first thing is the silicone, no matter how thin the capsule, the silicone should not rupture into the chest, because that is where the expertise of the surgeon comes into play, because sometimes the capsule is thick, sometimes it is super thin, it's transparent, as you will see in many of the Facebook lives, for example, or many of the videos. Now you have what is frank spillage of silicone within. Now you very likely had drains. So 100% you have what is residual silicone despite the usage of drains, which you likely had. And what needs to happen is, because I'm sure you're still hurting from the many signs symptoms of breast implant illness, correct?
Yes, I did. I immediately felt better, but then I've still got all the symptoms, and I think it was just in my mind knowing that they were out was a good feeling, but I've still got all the, especially
Right. No, so basically, remember, you don't need, so this is another very important point. You do not need you have to remove 100% of the capsule. You have to remove and absolutely make sure that 100% of the ruptured silicone implant is definitively removed from within the chest, basically with confirmation. Now, in your
Yep.
case, you very likely, and I use the word 100% likely, have what is silicone pockets within the tissue itself, because
Oh,
the
okay.
drain itself is not going to remove all those pockets. So it needs to physically be removed, especially where the silicone is very dense and it sediments down towards the lower part of the chest where the implants were sitting. Now, what happens is, so the body in itself will now start becoming reactive to that silicone. So that 10% capsule, for example, that remains, or that residual silicone that remains, now needs to be definitively, clearly removed. Because remember, it's causing that inflammatory response. Now, in the process, there are some lymph nodes that might potentially light up in the vicinity that might be palpable. Now, I'm not a big fan of removing those lymph nodes because then there is a risk for lymphedema. And we know when someone has ruptured breast implants, silicone in nature, you not only have that silicone burden, not only within the chest, but certainly also within the lymph nodes, and certainly also at different organ systems and tissues of the body. So going back to you, the good thing is your surgeon basically sent the capsule off and ruled out malignancy. The good news is, from what you are saying, that your surgeon removed the entirety of the capsule definitively, because that's important. Now, what you have is residual silicone pockets within. What my recommendation would be, because you are not feeling better and you have the same symptoms, and this is a very standard, typical postoperative course. The patient has a removal of the implants. Sometimes the capsules left behind, or the silicone pockets of ruptured silicone remains behind. The patient has this quote honeymoon period, a week or 2 or 3, and then all of a sudden the same signs of symptoms of breast implant illness come back. So what you need is a physical excision removal of the silicone that is at the bottom. Now, what I would recommend to you, if you were to be my patient, to get an MRI with and without contrast. And we're specifically looking for silicone pockets. So wherever there's inflammation, the IV contrast will go and highlight the areas that are more inflamed than the less inflamed. And I have seen from my workup, there are pockets of silicone granulomas that may form, or pockets of silicone that will sediment and accumulate in certain areas of the chest where it was not completely drained, where the drain did not reach, for example. That needs to be physically removed by palpation, by the finger, by visualization of the abnormal fatty tissue, by even the thought process that is this questionable or not, you physically remove that tissue, sometimes even at the expense of the aesthetics, so that all that silicone burden toxicity is definitively removed, sent to pathology, and your body hopefully gets the best chance to bounce back. Now, if there are any lymph nodes in the axilla area, because that's where the silicone is going to travel to, if they are palpable or notable, then those large ones selectively can be removed later on at another setting if needed, depending on the post-operative course. So on myself, in my practice, I have removed a lot of patients who had a first set of implants, silicone then ruptured, then she ended up getting silicone or saline. So for me, the burden is not only to remove the intact implant plus the capsule, but to also remove that silicone that had ruptured, that had now sedimented. And this is where I get the MRI for the patients. So it is mandatory for me to remove that for the patient to bounce back to a state of good health, minus all that silicone rupture that did occur. Now, there is no leaching agent, there is no agent that will, quote, accumulate all that silicone that may have basically spread to the periphery or even to the different organ systems of the body.
That was such a great question there from Stacy. We have a few other questions here in the chat for you, Dr. Khan. The first is kind of going back to what we were talking about before. It says, could breast implants cause hypothyroidism or Hashimoto's? So
that
is
is
it
a
the
good
cause?
question. Yes, I don't think it is the cause, if you ask me. It certainly, there is no direct, you got implants, and because of the implants, you got Hashimoto's. There is no literature to date, no scientific study, and no evidence to prove as such. Millions of patients have Hashimoto's and they do not have implants. And the many patients who have implants do not have Hashimoto's. There is no correlation between the two. What I would say from my belief, and again, this is anecdotal, And from my scientific knowledge, the implants do not cause Hashimoto's per se.
That was a very good question, and a good distinction between causation and correlation, because what it sounds like is you have not seen either one of those.
Yes.
So the next question that we have is it's someone who's seen 2 plastic surgeons in BC, British Columbia, who both say they don't remove the capsule and do not give the patient the implants after the surgery. So to see or to keep them. Is that normal in Canada? And then I'm going to add on top of that, because that is part of your procedure. If once you've answered the, is it normal in Canada, can you then walk us through your procedure and why you do both?
Sure. No, it is important for the patients to get their implants back. There is no reason not to. Now, there might be a committee, an operating room committee that might decide, because remember, it's all socialized medicine, that may decide, well, you cannot just walk out of your hip implant that you had and you were not happy with it, or it got infected. But in this case, you want to see the implants. For example, if someone has saline implants, or even silicone, even if they're ruptured, remember, they were inside the patient. So holding them, you're not going to get toxicity. Remember, you can go touch something, debris. You want to hold with, let's say, gloves, for example. It is consistent with slime, if you will. Now, going back to, there is no indication for that. Now, for example, I used to normally, when I would do the cases at the hospital would allow me to give the implants directly back to the patients. Now the committee said, well, we need to have an order to the system. So now they actually have a release. And I myself put forth this mandate that the patients must get their implants back, because they want to be able to see an intact saline implants. How many patients have I talked to where the surgeon goes in and deliberately, purposefully ruptures the saline implants and removes it from a small pocket and says, I removed the implant plus the capsule. So this is, again, part of the 5 criteria that I say where you can be certain that the patient had the entire implant removed completely, definitively. And what is the status? You want to have psychological, mental closure that these implants that were inside you, they are definitively outside of you, and then they match the lot number, they match that these are indeed the implants that they got. 2 weeks ago, I did a patient, she had what were saline implants, she stated to me via history. And now post-operatively, I'm removing silicone implants. So I told her, these are your implants. And so she now knows purposefully, definitively, that these were the implants that were inside her, so that she knows that there was closure to all of this. The other very important thing, now remember, this is the heart and gist of what is explant surgery. Your surgeon should happily, very assertively and confidently, himself or herself, tell you that the capsule must be removed. You should not be pulling this out of your surgeon's mind that they have to do this. I have some of my friends, they have had some patients present to them and they say, well, I don't remove capsules, but if you want me to, I will go ahead and do so, because normally that's not my practice. And I will tell you, when the going gets tough in the operating room, the surgeon will not remove the capsule, because he or she does not believe in their mind that the capsule must be removed. We know for a fact there are many patients who have had partial removal of the capsule or no removal of the capsule, and then once they explanted, they continue to have the many signs and symptoms of breast implant illness. And only when they did go back to another surgeon who removed the residual capsule or the residual silicone that had spilled into the chest, or the complete definitive removal of that capsule was then done, then only did the patient bounce back to a normal state of good health. We also know from the many pathology specimens from the capsules that were sent to pathology, they harbor within them the breast implant particles. So removing the implant alone is not sufficient. Leaving the capsule behind will continue to trigger that silicone toxicity that exists in the capsule. And we know of case reports where the capsule that was left behind, for example, in the case report that is in my private breast implant illness support group page that I put forth, it's published and well read. This patient who had successful removal of the implant without removal of the capsule ended up 4 years later getting BIA, which is the breast implant associated anaplastic large cell lymphoma, from the residual capsule. So again, the point being, number one, Only when the residual capsules were removed did the patients bounce back to a normal state of good health. And number two, we know from the pathology that the capsules harbor within the breast implant particles that continue to cause the silicone toxicity. So it is imperative, it is extremely important, it is to the heart of explant surgery that all of the capsules must be definitively removed off of the rib. Majority of the times it is underneath the muscle, directly on top of the rib, which means that the fascia of the intercostal muscle, along with the fascia of the serratus anterior and the pectoralis minor fascia, along with the periosteum and the perichondrium. These are the fascial layers directly on top of the rib, plus the muscles on the chest that need to be removed, along with the implant, along with the capsule, along with all inflamed tissue, such that there is no inflammatory burden left behind. Because if it is, then that will continue to cause the trigger of silicone toxicity and the breast implant illness. And once this is removed, the capsule must be sent to pathology to rule out the BIALCL, the squamous cell cancer, breast cancer, any abnormal pathology that might be present. And I also, and this is again the con procedure that you mentioned, this is what I do. As you will see, I do not use drains. The last time I used drains was well over 3 years ago. And the many patients that I have had that have successfully explanted along with the capsule, and the many patients that I've taken care of who have had ruptured silicone implants where none of the silicone spill into the chest, because that's the ultimate test for the surgeon. And number two, this is not the time to be doing a lift which is at the level of the skin. This is the explant surgery where the whole focus, 4 hours, is what I take to commit to what is to complete removal of the implant capsule plus all of that inflamed tissue. Sometimes, for example, a week ago today, on a 8 days ago, for example, I took almost 6 hours to remove the implant and capsules, because that's how long it took for me to successfully do that operation. This is not the time, because majority of the times a lift is not required. Sometimes I cut out the excess skin on the side, plus the way the skin rebounds. Plus, I make the horizontal cut, and I find from my practice a good 80% of the patients do not need a lift. And this is a good confidence. Again, the 72-year-old patient who had implants from 1988, she did amazingly well. To my surprise, even she was not a candidate for a lift, even at her age, despite the breast atrophy and the skin atrophy. And number three, 100% of the capsules are sent to pathology in my practice for a CD30 analysis, which is to rule out the BIALCL, rule out squamous cell cancer, rule out any abnormal pathology. Number four, 100% of the time I send cultures for microbiology for aerobic, anaerobic, and fungal cultures. I have had patients with positive cultures for bacteria like Propionibacterium machinis, mold, and then I have referred them to infectious disease for definitive workup. Some of them have even gotten a fungal IV therapy for months in order to correct the underlying fungal infection. I also always, as mentioned above, return the implants to the patient. It is important to return the implants again. So there is mental closure, there's physical closure. Then again, the patient can verify, confirm that this is the same lot number, serial number that was given to them. These are the same set of implants. Believe it or not, I have had implants. One was saline on one side, the other one was silicone. One was meant on another patient, one was Mentor, the other one was Elegant. On another patient, the implant was above the muscle, the other one was below. More than half of my patients do not know what type of an implant they have, if they have Mentor or silicone. A patient that I talked to this morning at 6 o'clock from Canada, she does not know if she has saline or silicone implants because her augmentation was done 18 years ago. So I told her, she has had the mammogram and the MRI, and we can look at that to figure out. So there are ways to figure out what type of an implant patient has. The next thing, which is extremely important, is the twilight anesthesia or the deep sedation. There's two types of anesthesia, if you will, kind of a big, broad picture. The first one is the general anesthesia that we all know of, where the patient is paralyzed and now the tube is put down and the patient is now at the mercy of the machine that breathes for the patient, and the patient is paralyzed. It is very safe. It is where, for example, how colon resections, gallbladder insertions, mastectomy patients go through that. Now, what's even safer, better, more comfortable, and practical for what is outpatient surgery is this twilight anesthesia, deep sedation with propofol fentanyl, Versed, and maybe at times ketamine, where the patient and the basically the local nerve block that I give with the lidocaine, epinephrine, and marcaine, where it serves as a very effective anesthesia, where less risk for clot, less risk for aspiration, amongst other problems, where it gets the job done with the patient bouncing back. And to date, not a single patient has had any recollection of the surgery or had woken up. Very effective, very safe. I also take the seventh point being, I always take pictures of not only the implant plus the capsule, but also the chest, which is probably the most important picture to show that the entire capsule is definitively removed and that no capsule remains behind. Because remember, this is the heart and essence of explant surgery. This is what your surgeon is striving for, which is the 100-100-0 rule that I coined, which is 100% of the time, 100% of the capsule must be removed with 0% of the capsule remaining behind. Because if any of the capsule remains behind, that silicone toxicity burden will continue to haunt the patient and hurt the patient till she then goes and gets the surgery code done by a surgeon who has the expertise. Now, this is relatively speaking very involved surgery. If you go to 100 plastic surgeons, I will assure you with confidence, 90 of them, if not more, will outright state that they don't want to do a surgery where they're dissecting off of the rib. They will cauterize the rib or the capsule on top of the rib or the capsule on top of the serratus anterior or the pectoralis minor, which is not enough. That is incomplete surgery. The entire capsule must be definitively, sincerely, religiously removed, because if you leave any of that behind, the patient will not bounce back. And in order to show the picture and the high definition video is always done by me and my staff, and I take that to show that I did complete removal. And I will say last but not the least, the same surgery is offered to my patient who's the 25 healthy and no meds versus another patient, for example, she had 2 open heart surgeries, or another patient, she had an ejection fraction of 40%, or another patient, she had metastases to her neck from what is stage 4 cancer. And these are the patients I would do at the hospital, because at my private outpatient surgery center, I only do what is safe, healthy patients, because this is the right setting. The hospital setting is meant more for the patients who have underlying major health issues. For example, a patient who is on 5 liters of home oxygen at night, she is not a safe candidate to be done at the private surgery center. And the same surgery is offered. I hear some of the surgeons offer, let's say, a compromise surgery where they will leave the capsule in the interest of time, just to remove the capsule that is easier on the upper aspect or the lateral aspects. No, you want to remove the entire capsule, because you don't want to do a partial surgery for, quote, the more sick, the more physiologically involved patient, because she deserves the same standard and the best of care, just like the young patient or the middle-aged patient does. So I have operated on an 81-year-old, 75-year-old, 78-year-old in the same manner that I have offered surgery to the young patients. And
you
this
can
is
definitely
essentially
tell, Dr. Khan, that your procedure here has your wellness and the care of your patients at the top. That's your number one concern. So I really appreciate this procedure that you've put together. We have a bunch of questions piled up for you. So I'm going to move on to the next one, which is somewhat related. It says, what is SCC breast implant capsule concerns FDA have alerted? So,
I'm sorry, can you ask me the question again? What is the CC?
sure. I think it's what are the SCC breast implant capsule concerns that the FDA has alerted to?
So the FDA has the concerns in regards to the capsule that they're associated with the breast implant associated anaplastic large cell lymphoma. This was the warning that came about a few years ago, where France was the first country that literally banned the textured implants. And as you will see, they clearly mentioned that textured implants are associated with breast implant illness, but also others meaning saline implants and also smooth silicone implants are also implicated in behind what is BIA, breast implant associated anaplastic large cell lymphoma. Also, if I may mention, this is absolutely accepted by the entire plastic surgery society, and certainly by the FDA has highlighted that this is underreported because plastic surgeons are not sending the capsules to pathology, and because they're not doing the CD30 analysis, this cancer is being missed, misdiagnosed, and not appropriately treated. And this is certainly underreported. Also, just recently, last October, the FDA highlighted what is the squamous cell cancer that is associated with the capsules. This is, again, a very remarkable and an important warning by the FDA to alert the many plastic surgeons, including myself, where squamous cell cancer is now associated. And I'm confident that now, because of this information and the alert and the warning, all plastic surgeons must, not should, must send the capsules off to pathology, because if you're not doing the CD30 analysis, you're likely missing the cancer and the patient is getting disservice. My patients, once they get their explantation done and the capsules removed, they have the final pathology report and they have the peace of mind that it is not cancer. And then moving forward, they don't have to worry about it because there is closure to this. So it is imperative, extremely important, that the capsules be checked for not only the BIA-LCL, which is the breast implant associated anaplastic large cell lymphoma, but also checked for squamous cell breast cancer, which has also been reported in my practice, and also other benign tumors, for example, fibroadenoma that has been picked up in the pathology specimens, and also fat necrosis, among other problems like giant cell reaction, chronic inflammation, histiocytosis, for example, amongst other cells that are reported to be a direct cause and a reason for the illness of breast implant illness.
Thank you for that great answer to the question. I'm going to ask the next one because Cheryl has been waiting a while for an answer to this question. Would you operate on someone with obstructive hypertrophic cardiomyopathy?
So I operated on a patient 37 years of age. This is right during COVID, by the way. This was in May when all the hospitals were shut down and they were doing what is only essential surgery. So at 9 in the morning, I operated on a patient with significant pulmonary hypertension, and she's the one who had the low high. So I will operate on her as long as she has the cardiac clearance and optimization, and she has the right lab workup, because some of the patients are on water pills. I want to make sure they have a normal potassium, and this is why she would be done at the hospital in a very safe setting so that we can do the appropriate lab workup. And God forbid there's any issues, we have the whole hospital to our access, God forbid anything bad were to happen, so that we're all prepared. In a setting like this, I have my pre-admission testing, people be aware of the file, and the clearance is granted by the cardiologist so that we can proceed in a very safe manner.
Thank you.
You're welcome.
I think this next question is going to stump you. So if you can't answer it, we have the email address of the person who asked it, and we can follow up later. So it says, is there a doctor in South Africa, more specifically Cape Town, who you could recommend to do an en-bloc explant?
So I will tell you, I talked to a lot of ladies from literally all over the world. I have had patients from Germany, Japan, from Panama, from the Dominican, from the Netherlands, and from Qatar, from Saudi Arabia that I've talked to, literally all over. I will tell you, from what I know of no one in that part of the world, specifically South Africa. Now, this is a very important question. You should seek a surgeon who actively talks about it, who, number one, should not be augmenting, because I will tell you, if someone is augmenting, that is putting in saline or silicone implants, he or she likely will not believe in breast implant illness. If I didn't believe in breast implant illness, I promise you from the bottom of my heart, I would be doing 6 augmentations tomorrow, because the financial reward is 3 times, 4 more times than explanting, without a doubt. Number 2, you have to have a plastic surgeon who willfully, happily, with all might and with enthusiasm, be actively talking about breast implant illness for him or her to do the right surgery. Now, I say to you, I see a lot of surgeons across the country, not only here in the US, but other parts of the world. When I see the feedback that I myself, when I talk to the patients, oh, the surgery was done in half an hour or 1 hour. I will tell you from my experience, it cannot be done that fast. I see some surgeons doing what is an explant surgery and a lift in 3 hours. That is physically impossible. Just to do a lift alone would take any good reputable plastic surgeon 3 hours, for example. This, and how can you throw in an explant for free, right? That in itself takes me 4 hours, 5 hours, 6 hours. Sometimes I've started my third case at approximately 6:30 p.m. Now, I have 5 criteria that I say that certifies, authenticates, gives confidence that your surgeon is doing the right thing. Number 1, the length of time for the surgery should approximately be 4 hours. Number 2, the length of the incision. If they're removing 500 cc implants, you cannot have a 3 centimeter incision. You have to have at least 9, 10, 11, because that's the way the surgeon will be able to see the entirety of the capsule directly on top of the rib in order to remove it completely, right? We don't want to leave any of the capsule behind on top of the rib. Number 3, you want to have the implants returned to the patient to see that the saline implant was not ruptured. There are so many patients that go to a plastic surgeon. Just yesterday, I talked to a patient. She said, my plastic surgeon said, I'm going to rupture your implant with an 18 gauge, and then we will see how your breast tissue recoils 3-6 months later. If you don't recoil, then you will need a lift. That's how I would tell. This is absolutely a big no-no. So you want to get the implants back. Number 4, you want to get pictures and videos clearly showing that the entire capsule was removed. And 5, last but not least, your plastic surgeon should have a reputation online. I have a reputation online that I do not put in implants. Anyone in 2023, a plastic surgeon, board certified, should not be putting in implants if they believe in breast implant illness. You cannot have it both ways, where you believe that the earth is round, but at the same time, you turn around and tell the other person the earth is flat. You have to choose one or the other. And eventually, as you will see, breast implant illness is going to afflict each and every single patient who has an implant, some sooner, some later, right? Look at the 72-year-old lady. She comes to me 35 years later. She started getting the negative effect 33 years into her augmentation. Wow. I have had a patient that I took care of 4 years into her augmentation with silicone implants. One was ruptured, and how do we know which one is which? Now, remember, look, if you listen, I say to you, don't listen to what I have to say. Listen to what the FDA is saying. The FDA is saying the implants are not meant to be in the body forever. They last anywhere from 10 to 15 years. I say to you and to my listeners and to any plastic surgeon, from my anecdotal experience, they last anywhere from 7 to 10 years before they start causing problems. Remember, they're clearly not meant to be in the body forever. Look what I said earlier, with silicone implants, you're supposed to get an MRI at year 3, and then every 2 years they're onward to look for what is a silent rupture. You may have a, quote, a perfect exam, and you could have a ruptured implant, surprisingly. So no plastic surgeon in 2023 should be putting in implants. Number 2, the BILCL, the squamous cell cancer. And number 3, there is clear mention by the FDA. These are not my words. You will see they mention that the patients have breast implant illness, autoimmune issues, chronic fatigue, and that, if you look at the second last line, some patients report complete resolution. There is evidence by studies that are being done that 90% of the patients have resolution of their many signs symptoms of breast implant illness. Now, if I tell anyone, if you look at just the warning by the FDA that implants are not lifetime. So for example, if a 20-year-old patient is getting implants, so in her lifetime, she's going to at least replace them 6 times, as on average, the last 10 years, plus the many other problems associated, including cancer, including all this joint pain, muscle pain, chronic fatigue. I will tell you, any reasonable person would run and not even consider. If you look at, Michigan, we live in a motor city. If I tell you there is a car that the manufacturer is making, and it will break down in 10 years, maybe sooner, maybe later, that it will break down, the engine will catch on fire. This is the cancer, if you will. Or the third, you're going to have axle transmission problems, among other electronic problems, be it the autoimmune, chronic fatigue, brain fog. You would not even look at the car, even if you would not probably even want to drive it, right? So going back to the same point, look at these warnings. Now, one has to objectively look not only at this warning, but let's say now in 2023, look at what the patients are reporting. They are so happy. Look at all the Hollywood stars, for example, the Danica Patrick, for example. Look at all the many other ladies who are now coming forth in the masses saying, look, I am back to thinking again. I can see better. Like my Sjogren's of the eyes is dramatically improved. My depression, anxiety, my neck and back pain, and all these symptoms. And we have overwhelming evidence. You don't even need to talk to the ladies. Just go to Google and type in before, after explant photos, and you just see with your own eyes within hours, once the surgery is done right, complete resolution. These are not my words. These are the words of the FDA. Complete resolution of their signs, symptoms of breast implant illness, and there is closure to what is a real problem with a real solution. So hopefully
That's
this nice
absolutely
lady,
incredible proof there.
yeah,
And I can tell
yeah.
that you're so passionate about breast implant illness, and you had some great advice there for folks who are looking for a surgeon and what they should look for if they're not able to come to you, to make sure that they're getting the care that they receive.
Again, I will say this to you and to everyone else. I can only do so many of these in a year. And I'll tell you, for me, my passion, and again, this is the purpose of this live and this Zoom meeting, is to raise awareness so that a surgeon in South Africa, hopefully soon, will be able to offer it in without drains, with all the factors and the points that I pointed out. So that patient, when she has her surgery, today I did 2 cases. My 2 patients today, they're sleeping sound with the pillows under their head, and they know all the capsules been removed and the definitive workup. So you want to have the peace of mind. There should be no second guessing. There should be complete willful happiness from the plastic surgeon to be doing this so that the patient is bouncing back to a normal state of good health. The worst case scenario from my experience, as I talk to the many ladies all over the United States and all over the world, is I had my explant surgery done and my capsules were deemed so thin that they were not removed. I'm still hurting from breast implant illness. Can you please remove my residual capsules? This is the worst case scenario. Or like this very nice patient she mentioned, my surgeon went in, he removed the whole capsules, but the silicone ruptured into the chest. The whole challenge of the surgery is how and what care did your surgeon take in order to make sure that that silicone capsule was not going to rupture? I will ask that first question. How long did your surgeon book the case for? If this case was booked for an hour, I assure you with absolute 100% confidence, there was no willful desire to remove the whole capsule. I myself, when I go in, I sometimes ask myself, there was a patient that worked for the governor here, for example, in Michigan. I spent 3 hours just on the right side, and I will tell you, I was badly beat up. There was a case I did on on a Tuesday, where after the second case, I was tired and I was just exhausted, and I had a third case, and I told my patient, the third one, I'm sorry, we're going to do you Wednesday morning, the next morning, because I physically am not ready and mentally prepared to do your surgery, because I don't want to be going in. The next thing you know, I'll be coming out at 11 p.m., which I have done before. So the point I'm trying to make here is, if you look at the history of that surgeon, for example, to answer this nice lady's question using the first lady's question, how many of that first patient surgeon, how many of those surgeries has he or she done with all due respect and professionalism, where you want to have a track record so that going into the surgery, you know it's ruptured, you know you're going to remove it with absolute care, such that even if you cut into the capsule, you can still plug in that capsule, you can suture the capsule, you can suction device that silicone out. There are many tricks and modalities where I have not removed en-bloc 100% of the time, and there is no plastic surgeon on earth who will do en-bloc 100% of the time. The en-bloc is where there is no breakage into that shell, and that the entirety of the implant capsule, where the entire capsule is pristinely preserved. If that cannot be achieved, and certainly cannot be because the implant is sitting plastered onto the rib, then the next best case scenario is where you have 100% total capsulectomy. And despite a silicone implant that's ruptured, the surgeon is smart, wise, and skilled enough that he's able to MacGyver himself, if I can use that word, out of that silicone spilling into the chest, because that's the catastrophe that is going to be very, very hard to manage. You don't want to make that happen. You don't want to be in a situation where there's frank spillage of silicone. Now, sometimes it is unavoidable. That one point that lady, the very first question she mentioned was the silicone was not gel-like. It was very honey type consistency, which is probably the older technology. Sometimes it is unavoidable, and that's probably what happened in that first surgeon's case, if you will.
Yeah. So we have a related question here. When you reference the fact removing capsules and sometimes needing to remove the fascia and pectoral tissue, does this regenerate and repair itself over time, or is this fascia and tissue permanently lost?
The fascia and tissue is lost. Now, this is where someone is, for example, getting a facelift or a tummy tuck or a thigh lift. This fascia sometimes needs to be removed, right? And so it is not, which is worse, to remove the fascia or leave the capsule behind? And so the answer is very simple. Take the fascia, because if you leave the fascia behind, you're leaving the capsule behind without a doubt. So as I do the surgeries, if I'm sitting on the fence and there have been times, should I remove it or not? I err on side of removing it because I cannot visualize and see it is or it is not, because the pathologist is the one who's going to be able to tell what type of cells there are, even at the expense of the aesthetics. I will say, yes, I will cause asymmetry because I'm removing more inflamed tissue. The last thing I want is my patient to look good, but be hurting from a breast implant illness. I would rather have her be happy and free of breast implant illness. And all the ladies, they have suffered enough where they will gladly accept that mild period, short period of time, because remember, we can always correct the problems later on. That is a much easier fix than, and I do my level best to correct the problems on the table such that I tackle the problem right then and there as a board certified. Because yes, I'm absolutely concerned about removing all of the capsule and inflamed tissue, but absolutely I am equally very concerned about the aesthetics so that patients feel good and look good.
We have a whole bunch more questions for you. Let's
No, please,
move on to
I
the
will go ahead
next
and
one.
answer. Yes, yes.
And I know you say you don't use drains. So this is a question about what other surgeons may be doing. So it says, are the drains used to remove silicone left in and the fluid that body produces? She had drains for over 2 weeks and drained over 1 liter from each breast.
So I will say this to you, look at my practice. Like I said earlier, the last time I used drains in any of my patients, I have not used drains in any of my saline patients. And in my many patients with ruptured silicone implants and intact silicone implants, be it textured or not, I have not used drains simply because they're not required. I take it upon me to very meticulously, diligently, very in a skilled way, remove in an avascular plane all of the inflamed tissue, and I'm removing all the badness, if you will. If you look at any of my YouTube videos and Facebook videos, sometimes, because of the graphics, they will not allow this, but YouTube, you certainly can see, and look at any of my pictures on Facebook. My blood loss, 97, 98, 99% of the time is well under 5 cc's on each side. So my total blood loss is 10 cc's. There is no residual burden left behind, so the need for the drain is not there. 1 liter is a lot, even after a tummy tuck, where a vast area on the belly, for example, all the way up to the xiphoid is dissected out. The drains are there for, if I do put in 2 drains, for example, they're there for 2 to 5 days, usually 3 to 4 to 5 days. So 2 weeks of drains, putting out a liter is a big, I use the word danger in a sense. Remember, the drain could open, things could backflow. Remember, this is also a very important point. If the silicone spills into the chest, or there is residual capsule remaining behind, or residual capsular burden or inflammatory burden left behind, then it is mandatory to put in a drain. So I myself, for example, I operated at the hospital on a 68-year-old lady. As soon as I made cut, and I knew going in she was sick, that's why I did her at the hospital, there was pus pouring out. I had to put in 2 drains, not only 1, because she needed it. And the drains were out by day 5, day 7. Now, in the one case where, for example, 81-year-old lady, she had a car accident and she spun on ice and hit the steering wheel and she was on Coumadin. She had a hematoma, which is a collection of blood because of the thin blood, and she had frank silicone mixed with the blood. As you can imagine, she absolutely needed the true drains. The point I'm trying to make here is once you have spillage of silicone inside or silicone toxicity or inflammatory tissue behind, you have to put in the drain. I myself remove all of that by the care, by the expertise, and look at when I do dissect, the blood loss is less than 5 cc's on each side. There's less tissue damage. The muscle is not cut up and down, which most of the surgeons cut up and down from the nipple areola down. I cut sideways only, so I hide my incision. Number 4, there's less trauma to the tissues and less pain post-operatively and preservation of the aesthetic breast tissue. So the need for the drain is not there as a result. And, you know, as you will see, some patients ask, I wanted to put drains because every single patient, every single surgeon that I've talked to has put in drains. I want you to put in drains. I don't mind. I said, I'm not going to put them in because you asked me. I say, look at my track record. I have not put in drains happily and safely, and the patients don't need it. And I have a track record. And I request my colleagues to see how I do the surgery. And again, it is very precise, removing all of that inflamed tissue. And as you will see from the Facebook posts and the YouTube videos, this is done very safely, very effectively, where the only thing that I'm doing, and I use the word only, the only thing that I'm doing is removing the implant capsule plus all inflamed tissue and leaving behind all good, healthy tissue. I do not touch the breast tissue. I don't need to, because the moment I do, the breast scar tissue is going to form. You're going to find that the necrosis of the fat in and around the proximity of the breast tissue is going to occur. Breast pain, because of the many nerves that supply the nipple areola breast tissue, is going to be affected negatively. I want to be able to dissect where majority of the implants are below the muscle. I stay below the muscle, removing the implant capsule. I don't need to go into the breast tissue area, if you will. So my patients safely, with a proven track record of the many patients with even the many ruptured silicone implants. And I've done Facebook Lives, you know, so this is clear, direct evidence. I have not used drains safely and comfortably for the patient because they're not required.
And I believe that is your number one point in your COM procedure. Moving on to our next question, and we seem to have a lot of thyroid questions. So we're back to thyroid Hashimoto's. Given that breast implants are considered an endocrine disruptor, could one expect improvement in thyroid function after an explant?
This is a good question. So I would anticipate yes, because what happens, and again, I do not know the answer to that. What happens in breast implant illness, the immune system goes on overdrive because you have a foreign body, and the body tries to fight this off with the giant cell reaction, macrophages, histiocytes, hemosiderin-laden macrophages, for example. You have chronic inflammatory cells. Now, what happens is, just like when someone has a cold, right? You're like so tired and lethargic and weak and kind of dehydrated. This is the same kind of overdrive. Now, we know clearly the hormonal system, not only the endocrine, but the reproductive system. Now, don't listen to me. Listen to all the ladies that present. They mention they have had premature menopause. This is another very important aspect of what is breast implant illness. If you look at that, the entire cortisol / hormonal system of the body is negatively affected. And so I anticipate, and again, this is not only true for Hashimoto's, but patients, for example, who have lupus or who have rheumatoid arthritis. I do not know, I do not guarantee that the patients are going to be free or their rheumatoid arthritis or Hashimoto's is going to be better. I would anticipate, because the immune system is now kind of calming down, that the symptoms are not going to be as worse. Again, I do not know the answer to that. I would assume yes.
So this is the next question that we have for you. You made a reference to this in an earlier answer, and I'm kind of curious myself, but it says, what is foreign body giant cell?
So foreign body giant cell reaction. So foreign body, that means the body recognizes the implants as a foreign body. Now, giant cells are a cluster of macrophages. What are macrophages? These are the inflammatory cleanup cells, if you will, vacuum cleaner cells, if you will, just to make an analogy, that clean up the debris, where they do by process of phagocytosis. If you go back to middle school physiology, the cells clean up the debris, the inflammation, acute and chronic inflammation, and the macrophages, a cluster of which form multinucleated giant cells. So what I want each and every one of you to do is go to Google and type in multinucleated giant cell reaction, and you will see clearly what I'm talking about, the macrophages, the cluster of cells that are responsible for cleaning up the inflammation as a direct result of the foreign body, that is the implant and the particles that are leaching into the periphery.
Thank you for explaining that. I was very curious myself. I did want to call out Brittany in the chat for saying that she is considering traveling to visit you. She is in Denver and would like to learn more and talk to you more. She also asked, what are dog ears?
So just like in any aspect of plastic surgery, for example, a tummy tuck, where you bring the tissue from the top down and then you match to the lower part. Now, sometimes the tissue at the top might be more than the tissue at the bottom. So if, for example, in breast explantation surgery, when you remove the large implant, let's say the 600 or 550, or with respect to the patient's chest large implant, you want to be able to bring the upper skin flap down to the lower skin flap and suture. Now, sometimes what happens is they do match up, but there is redundancy on one side. And what happens is there is an outfold of a skin that is called a dog ear. Now, if that does form, especially in cases where patients have what is a flat chest closure after breast cancer, that can always be later on corrected if that does occur. Now, sometimes if the patient has a radiated chest, ideally should not occur, because then there is discrepancy of the upper and the lower flap. And this is the artistry of the surgeon to making sure that these don't happen. And this is where there is a flat chest closure, so that once patient closes their eyes to pass their hand up and down, there is a nice smooth medium between the upper chest and the lower chest, and that there's a one fine line that hopefully is very, very non-noticeable. And that is the desired closure minus the dog ear, which is the outpouching of excess skin that was not technically removed by the surgeon. And this was not the surgeon's expertise. It happens even in the best of the hands, but that's usually sometimes a quick fix under local only, where you just give local, just like you would once someone has a like a root canal. This is 1/10 the intensity. You just cut out the excess skin and approximate the skin together with dissolvable suture, and that's the problem corrected right there.
That was not the answer I was expecting to hear, but I really appreciate you explaining that to us. We'll put out another call if anyone has any questions for Dr. Khan.
Sure. No, if I may, this is also important. I have a lot of patients that come to me from all over. So just this year, for example, from Hawaii, from New York, from Buffalo. I had patients from Utah, Arizona. This is just within the last 3 weeks since the New Year's. I have had patients from Maryland, for example, and again, Florida, Texas, California, a lot of California patients, literally from, I would say, every single state of the United States. Now, when they do come, I just want to mention it is absolutely 100% safe. And all one needs to do is, and I request each and every one of you to go to my private breast implant illness support group Facebook page, where you will see the many patients. It is a very safe forum where you get a chance to discuss with my previous patients as to the effectiveness and the safety of traveling out of state. Just the thought, for someone to leave, for example, California and come to Michigan for explant surgery sounds like sometimes like exaggerated, where you have such a high concentration of plastic surgeons just between San Diego and San Francisco and Los Angeles, right? Now, this is the whole concept of safety, where I have the clearance and I have the peace of mind, and I've talked to each and every single patient. Now, just like the patient has the right to choose me, I have the right to choose my patient. So I'm very selective about Just today, for example, I turned down that patient who had 2 clearances, one from the cardiologist and one from the primary care, despite what was a reassurance that she would be able to get the outpatient surgery. So once I get that, there are patients who are outright say, I'm not going to operate on you because she had like liver cirrhosis, for example, or another patient who had significant medical underlying issues where I thought she would not be able to even meet criteria for what is outpatient surgery. So going back to the point, it is very safe for someone to travel and to get the surgery done. So for example, this is the timeline for many of my patients. They do come in physically, for example, on a Monday. I get to see them and I examine them. They get to see me. Again, this is part of informed consent, and they see the facility. And I give them the prescriptions, and they basically reaffirm what they already know from the Facebook and the phone consultations that I've done, the discussions that I've had. And I already know them, not only I, but my nurse and my anesthesia team. So when I see them on Monday, they get the surgery done on a Tuesday. Or for example, some patients with saline implants, for example, they do come in on a Tuesday and their surgery is done the next day on a Wednesday. So the surgery is done, let's say on a Wednesday or a Tuesday, for example, after they have already seen me the day before. Then they recover the Tuesday, Wednesday, Thursday, Friday morning, they see me early in the clinic, like around 9 o'clock, 10 o'clock. And now the patients themselves have had 3 days, 2 days to recover, where we have enough time. And remember, a lot of determination is made on the day of the surgery itself, where I can say with definitive certainty that there's going to be no surprises, because if anything's going to bad that's going to happen, like a hematoma, for example, it's going to declare itself within the first 24, 48 hours. And that window has now passed. I thank God to say that I've had not a single infection to date where I've had to go back and remove pus from a patient, for example. I'm very happy to state that. All the patients have done well. There was one patient, for example, she had 800cc implants in her mid-50s that came to me from California, and she was a cancer patient on steroids. I just wanted to keep her 2 extra days through Monday when I had seen her a week later now. So because they were videotaping her as well, because the camera crew had come, and I just wanted to make sure that she was going to bounce back, because again, large implants with steroids and middle age. Going back to the point, so the patients stay the 3 days, and then when I see them on Friday, they themselves, as you will see, feel comfortable. I tell them to get travel insurance. Only a few patients, less than 5 or so, I would have had to stay the following Monday because they themselves chose to stay, for example, and they felt more comfortable. And then I follow them closely, sometimes on a weekly basis, sometimes at a week 3 and week 6 basis, and I'm able to follow them very, very closely. They are actually, I have like a very nice track record, and the patients, as you can see on the Facebook, they're very happy. There is no like drains 2 weeks later, because none of that is occurring, because none of that is needed. And this is where the best post-op care is pre-op care, and the best post-op care is intraoperative care, where 100% dedication is made. That one patient, she waited the 3 hours because it took me a lot longer to do my second surgery, simply because that was the extent of the surgery. That patient understands she got the best from me. There was no rush. There is none of us are wanting to finish early. We want to do the best surgery we possibly can, again, from the bottom of the heart, so that the patient knows this, and she got 100% out of me. And post-operatively, she has the best post-operative course. So it is very safe and very effective. Some patients do come, for example, on a Wednesday. I see them after my surgeries. I do operate on Tuesday, Wednesday, Thursday. Sometimes I do operate on Mondays and Fridays at the hospital, but I do operate at my surgery center on Tuesday, Wednesday, Thursdays, and I see them on their respective days. For example, if I were to see a patient on a Wednesday in clinic for pre-op Thursday surgery, I would see them on Monday for her to be ultimately flying back, let's say in this case, to Denver. And again, Jennifer at the front desk is very helpful, very resourceful as far as making sure. And ultimately, all my patients have my cell phone number. If there's any issues, they can reach me directly, not my answering service. That is also very important. I know only what happened in the OR, not anyone else. And I'm able to follow them very carefully, very, very sincerely, so that they get the best operative experience.
it's very clear that you care a lot about your patients and making sure they get the best care possible. Thank you, Dr. Khan, for taking time to discuss this really important topic with us. We are nearing the end of our conversation, and we appreciate you being here.
I know you're welcome. No, I just want to go ahead and thank everyone, each one of you. Please, I want the patients to discuss. The most important thing one can do is to basically seek consultation with other plastic surgeons. Every time you go in and talk to a plastic surgeon, now I want you to talk to the plastic surgeon directly who's going to be doing the surgery. You do not want to be talking to a PA or a medical assistant or a nurse practitioner who's not going to be in the operating room, who's not going to be doing the surgery. You want to hear directly from the surgeon. This is part of your right as a patient's bill of rights, right? You want to have the confidence that your surgeon truly cares. You should have that feeling that you can talk and approach your surgeon anytime because you have that bond, that confidence in your surgeon, and that you should not, I don't want to use the word afraid, but you should not be nice and saying, well, I don't want to waste your time. No, this is important because you don't want to be stuck afterwards with a bigger problem, if you will. And so I want you to talk to the surgeons, all patients, talk to the surgeon directly, ask questions. There's a series of questions on my website and others that you will find. I want you to do your own homework, use your sixth sense, guide yourself accordingly. Yes, this is a complex topic, but after some time, as you will see, it is not that too hard to grasp. I say sometimes to my patients who come to me from far away that if I give them a board and a marker, they will be able to give a lecture on breast implant illness because they know how I do it and why I do it in the manner that I do, such that post-operatively they have that peace of mind and confidence that they got the best surgery and they have nothing to worry about as they go back to their lives. I also want to mention that, ask questions in a very nice, assertive way. In a very professional way. This is your right. Again, you want to get this information. I say this to you and to every person who's listening. For example, that young lady from South Africa, if she were to come to the top 100 hospitals and she has, for example, saline or silicone implants, unfortunately, even from what we know now, not only from what the FDA has mentioned, not only that, but not only what we know from the many patients who have successfully explanted and who are happy and free from breast implant illness, but also, as you will see, hopefully the next discussion we can have about what the manufacturers themselves are saying about their own product, i.e. the breast implants, be it saline and silicone. You will see that there is a very clear and cut, defined answer. I will go ahead and take a couple of points. Breast implants are bad. They are not ideal safe devices. They're replete with problems. And these are the problems I will highlight. They are associated with lymphoma, squamous cell cancer, associated with capsular contracture, infection, asymmetry, pain. They're associated with scarring of the breast and the chest tissue. They're associated with the many signs and symptoms of breast implant illness, psychological disturbances. They're associated with ruptures. They're associated with the patient not wanting to get a mammogram because she's afraid she will rupture her saline implant or silicone implant because of the pain she has. And unfortunately, they're not going to be able to do the self-monthly breast exam. And now breast cancer is going to get missed and misdiagnosed, or sometimes some of the biopsies may not be done because this mass might be in the close proximity of the implant, and the radiology team / surgery team might not feel comfortable doing the biopsies. And rather than what would be a late detection of breast cancer, remember 1 out of 8 or 9 women are going to get breast cancer. We do not want to change the physical exam because the large implant is sitting on the breast tissue, and now because of the bottoming out plus lateralization of the implant or the contracture, the patient is not able to feel her breast tissue, and now the breast cancer is not being diagnosed. The most common way the ladies detect breast cancer is the self-monthly breast exam, number 2 being mammograms. These are enough reasons, as you will see, amongst the many others, where the replacement of the implant, that in itself, where eventually all ladies will succumb to breast implant illness, because remember, no one can guarantee you that the implants are lifelong devices. Look at the FDA clearly highlighting that. This in itself, if someone just listens to this last sentence, the last few minutes, you will be convinced without a doubt these implants, both silicone and saline, must be taken off the market. And it was a mistake by the FDA. And I will say this with definitive certainty. You have ladies that walk in with silicone toxicity, breast implant illness. I cannot tell by their exam and their symptoms if this is saline or silicone implants. They are interchangeable set of problems. And the point I'm trying to make here is the saline implants should have been banned as much as the silicone implants were banned. And I'll end with this. It's very clear that we can continue to have this conversation forever, right? And talk about the many detrimental effects and look at the literature that is now coming forth. For example, the Plastic Surgery Society out of Utah, for example, did a survey and reported, quote, 90% improvement in the many patients who successfully explanted. And the point here is we need to have this dialogue, this awareness. This is an excellent platform where we can answer questions for the many ladies that are ultimately hurting, not only in the United States, Canada, South America, Mexico, Europe, Middle East. And eventually, we want to improve the quality of life. We want to be able to reach the many such that they are aware that it is not anything but the implants that are causing them this problem. And there is a real problem with a real solution. And one needs to do their homework. And hopefully you found this talk, this educational series very informative. In the meantime, I encourage you and each and every one of my listeners to discuss, share this, for example, dialogue that we have had with the many patients who came forth. I appreciate them, and basically learn from each other. I encourage each other and inspire one another in a safe place, which is the Breast Implant Illness Support Group, not only my page, the Breast Implant Illness Support Group Facebook page by Dr. Khan, but also the YouTube channel. And I thank you very much, and Tess, Danielle, and Ali for allowing me to be a part to discuss this very important topic. And I look forward to seeing you all at our next talk. Until then, take care, all the very best, and keep smiling.
Thank you. We appreciate you being here tonight and sharing such informative and helpful information. Like you said, we plan to have more of these chats, so keep in touch with us. You can see all of the ways to do that right here. And we will be sending out a survey to each of you who provided your email address so that we watch for in your email. We'd like to improve these as we continue to do them. So thank you all. We wish you all a great evening, and thanks for being here.
Thank you. Bye-bye. Good night.